Hello and welcome to Lessons My Patients Taught Me. I'm Elliot Davidson, family doctor, your host. In this podcast, we discuss the great lessons we've learned from our patients over our many years in practice, and I talk to some very experienced and wise people, generally one at a time. Today's episode is a first for this podcast. It's our first roundtable discussion, and we're tackling a topic that's landing in exam rooms, hospitals, and inboxes, whether we're ready for it or not: artificial intelligence in medicine. I'm joined by an eclectic group of AI users. Dr. Peter Leone is an infectious disease specialist who's still active clinically but spends most of his time in industry working for GlaxoSmithKline on HIV vaccine development. He'll give us the industry perspective. Dr. Howard Abramowitz is a retired urologist who's been active in clinical research and uses AI personally and professionally. Each of these folks has been a guest on this podcast, and I could spend the entire time touting their accomplishments. If you want to know more, go back and listen to their individual podcasts. But suffice it to say, these doctors are very experienced, and they've seen many next big things come and go. Rounding out our group is Jenny Owens. Jenny is the Senior AI Administrator at the AI Center of Excellence at the Cleveland Clinic. She spent her career at the intersection of science, technology, and healthcare, starting at the lab bench, and now she's working at the strategic edge of healthcare IT and AI governance. In her current role, she leads AI adoption and governance within Cleveland Clinic, a physician-led health system. This means that she's navigating regulatory complexity, bridging gaps between clinicians, technical teams, and other end users, and she's building trust in AI for healthcare. In her spare time, she also hosts the Health Data Ethics podcast, where she explores the real-world implications of AI, data privacy, and algorithmic accountability in healthcare. She's an excellent AI expert to add to this discussion. AI is growing in nearly every facet of life. We've all seen it. The genie is clearly already out of the bottle. In healthcare, AI promises efficiency, accuracy, and relief from some of medicine's growing burdens. But it also raises real questions about trust, bias, responsibility, training, and the doctor-patient relationship. One challenge with AI is how rapidly the landscape is changing. Every day seems to bring new revelations and new uses. Utah recently became the first state to allow AI to refill over 200 kinds of chronic prescriptions, and eventually this will occur without a doctor's review. The Cleveland Clinic just touted 5 new ways it's using AI in its monthly newsletter video, including sepsis detection and MRI tumor mapping. What should AI do, and what should AI never do? What lessons from our patients should guide how we use it? Welcome, Howard, Peter, and Jenny. It is a great pleasure to welcome you all to the podcast Roundtable.
It's great to be here, Elliot, so thanks for the invite.
Glad to be part of the program.
Yeah, truly honored to be part of this discussion. This is going to be fun.
Yeah, so let's just start off with kind of an open-ended question for each of you. When you hear AI in medicine, what excites you the most and what worries you the most in your field? Peter, start us off.
Well, what I get excited about is the efficiency. So, I work both in academics and in pharma, and we've been encouraged, at least on the pharma side, to incorporate AI into our work plan, personal work plan, as well as teams. And so it's part of our emails, our every single meeting we have, we use Copilot for summary and putting together talks. And so I think the things that were rather mundane that we had to do, AI is actually able to do it very quickly. What worries me about it is that there's a tendency to think that it will reduce the number of people. And so I worry about losing some expertise that is really needed. And then the other part of it is there's something said about having teams in interpersonal contact. The way that you move ideas forward frequently requires just sort of picking up nuances around discussions, and sometimes AI really can't replace that.
Yeah, give us a little bit of your background. I don't know that I gave your correct introduction a little bit about what you do.
Sure. Well, I've spent most of my career in academics at the University of North Carolina in infectious diseases and public health, working in sexually transmitted diseases and HIV, which is an STD. And then I moved over into pharma about 8 years ago, where I lead a clinical team on treatment and cure of HIV using monoclonal antibodies.
Cool. Cool. All right, Howard, same question for you. What excites you and what worries you the most about AI?
What excites me is looking at medical education from medical school, residency. I remember carrying around little books of information to check on, and with the availability of AI, you can very quickly get a assessment of a medical issue and learn it very quickly. And it's right at the tip of your tongue. It's kind of like your pocket iPhone and looking on Google to check directions. I mean, it's potentially incredibly helpful. What worries me is that our future physicians may be so reliable on this technology that they they learn it at the moment, but they don't intrinsically understand the process to where it's part of their medical knowledge. You know what I mean? It's like calculators. Before calculators, we did so much math in our head. Kids today don't know how to do math in their head. They have to pull out a calculator. So I want it to be an augmentation to our learning process. And it has potential to be a fabulous tool.
Great. Yeah. All right, Jenny, tell us a little bit about your position at the Cleveland Clinic and your answer to this question.
Yeah. So when you say in my field, I guess my role at Cleveland Clinic is Senior AI Program Administrator. And what that means is that I spend about 51% of my time doing governance work and 49% of my time doing enablement work. So on switching back and forth very quickly between encouraging people to do more artificial intelligence and then laying out the guardrails and making sure that the AI that they're using is safe and reliable and validated and monitored. And so when I hear AI in medicine, I think about a couple of things. What excites me most is just the broad possibilities for efficiency, as Peter has called out. There are so many processes in medicine, in particular since the advent of the electronic health record, where our clinicians and our patients are interacting with the technology instead of with each other. And AI presents a huge opportunity to reduce that digital burden and put the attention back on direct patient care, which is where it really should be. What worries me is that we'll use AI to automate or calcify processes that aren't serving us or aren't serving the patient. Tennessee, there's several states that have laws on the ballot or laws going through committee about restricting the use of AI on the part of payers so that they can't automate their denials, that you have to have a human in the loop for those denials. I worry about the market forces of AI driving healthcare in ways that don't serve either our healthcare providers or our patients.
Glad to hear about what you said on governance because I'm still seeing patients clinically and I'm using the ambience tool that you selected to do my clinical notes, and I love it. I love it so much. Patients do raise an eyebrow when I introduce the concept to them, and many of them are worried that we're going to use their personal health information in a way. And I see online sometimes people saying, don't let your doctor do that, which I think is a huge mistake because it makes my life a lot more difficult if people start turning that down. But I know that we have to reassure patients that their information is not going to be used against them in some way.
That's really one of the interesting problems facing health systems when it comes to AI governance today is how do we communicate to a patient who is not in a healthcare AI context, right? They're in the world. They're hearing all of the cultural conversations about AI. How do we explain to them, here's what Cleveland Clinic believes is important about artificial intelligence. Here are the hoops that it had to jump through to make it into this exam room with you today. You can choose to trust it or not. That is your choice, but we want you to know why we chose to trust it.
Yeah, now reality check, and anybody can chime in on this. Where has AI already meaningfully helped clinical care, and where's the hype a little bit ahead of the evidence? Who wants to chime in on that one?
Well, I'll jump in. I think, Howard already alluded to it, the ability to actually pull together information very quickly. And I mean, I'm only in clinic a half a day a week, but there's all these checks and balances now that are AI programmed so that there's abnormal labs or trends that come up, it gets flagged. Something that when you're in a busy practice or you're bouncing from uh, consult to consult, you might miss. So I do find that the safety net is a little bit better overall. From my work in pharma, it's the ability to quickly look through all the world literature. Now, you have to know something about the field, You can summarize data pretty quickly. The downside to me with that is finding that medical students don't read anymore. They use AI to summarize rather than actually knowing how to read an article.
Anybody else want to chime in on that? I'll chime
Can
in.
I?
Oh, yeah, go ahead, Jenny.
You first, Elliot, because I've got some thoughts on this.
Well, I want to chime in on, just to reiterate what I said about the ambience tool, for the clinical notes. That is a game changer for reducing physician burnout. We've been doing this for, I don't know, close to a year now, and it is so helpful. And if I happen to forget it or it doesn't work or whatever, I'm depressed about that particular case because then I have to kind of recreate it. And we just now extended it to third-year residents, and they love it because they are overburdened with a lot of different things. And the notes that are created are excellent. And the after visit summaries with the patient instructions are also excellent. They're much better than I would create on my own. And it's amazing the detail that it picks up on any kind of information that I give the patient, even during the discussion, even before the end of the visit, but during the visit, if I give them, exercises, or I suggest a consultant, or I suggest a dietary change, that's all in the after visit summary. And so those I think is a huge benefit for patients. So I just wanted to make sure that people understand what a significant benefit that is.
Yeah. I'm really proud of the work that Cleveland Clinic has done on the Scribe tool. It truly is. And I was, Elliot, you and I talked extensively about the pilots that we ran, and I was really proud to be part of that team. I think one of the things that made the Scribe pilots such an actual success is that we had a really clear vision of both the problem and what an actual solution would look and feel like. Like, we understood what it meant to spend less time doing documentation outside of your scheduled hours, and we knew how to measure that. Conversely, we're talking about areas where the hype is ahead of the evidence, and I feel like I get maybe 20 or 30 proposals a month, like solutions for a problem that we do not have, or for solutions that cannot be measured. And so, when I get somebody, I don't know, Peter, Howard, if you guys get pitched, things where you say, oh, well, you'll just use this tool and it will improve, your patient flow, or it'll improve your scheduling, or it'll improve your data entry as you're registering new patients. And you're like, great. How am I going to measure it? And they're like, well, it'll just be better. That that's not the way any of this really works. Like, we have to be able to measure and to monitor and to point to that actual success. And so I'm concerned that we have, because it is today so easy to build tools, that we end up with a lot of solutions in search of problems.
And I'm going to chime in a sec. I'm very disappointed I did not get the benefit in my practice of AI scribing. Because I remember after seeing the patient, I'd go out and dictate in my EMR on Dragon and edit it while I'm doing it. And that's time consuming. And I'm very jealous that this technology is out there now. And I know it because I see when I go to the physician, they're using it, whether it's orthopedist, the neurosurgeon, the urologist, the cardiologist. Those are the doctors I saw this past year. Anyway, that is an amazing improvement. What always bothered me the most with a physician-patient encounter was that the doctors would be looking at the EMR and not talking to the patient. I know I made it a point never to use the EMR in the patient room. If I had a question, I'd step out, look it up, come back, because it was frustrating to me. Patients don't want to look like or feel like you're treating the computer, you're not treating me. Now, my concerns with AI is that we will get so efficient that they will now start putting more patients on our schedule. So instead of seeing, I would see on average 10 patients an hour, a lot. I mean, it was crazy. And I'm doing procedures during that time. But now they want to throw in 2 or 3 more. So you're making yourself so efficient that now you're overwhelmed. I don't want to see that happen.
Yeah, I'll add on to that, Elliot. In pharma, again, it's about efficiency. Time is money, much like it is in clinical practice. And I do worry that it's all coming down to speed. And there is a sort of process that you have to sit and think about things sometimes. And the efficiency doesn't necessarily mean that you can get things done quicker. It just saves time in other areas. I hope that there'll be more of an iterative process that as we free up sort of the mundane, you allow the creative process. It's still pretty unique to humans to be done. Never mind the whole interpersonal empathy and interactions that happen. So I worry that there's too much pressure about getting things done faster, quicker, and as Howard's already alluded to, adding more work on to folks that might burn out. So we're saving time in one area, but we're adding on to it. In addition, I still find that you have to go back and check what AI spits out because there are times where it generates data and hallucinates. And so there still has to be some oversight. I think that'll improve over time, but we're not quite there yet.
Yeah, I've noticed that in the clinical note or in the after visit summary, sometimes it'll get the name wrong of the consultant that I'm using, or it'll get the dose wrong of the medication I'm recommending. Let's say the insulin dose is incorrect, so I have to check that. So those are some things that you definitely have to make sure that is correct in whatever the patient is getting when you're finishing that up. Next question I have is for Howard first. Do you worry more about AI being wrong or about clinicians trusting it too much?
And this is a good question. I was very concerned that AI might give us false information. I've been retired, but I probably get 2 or 3 patient calls a week asking advice. Granted, a lot of times it's urology, but, my closer patient friends may want recommendations or run something by me for the trust that I've had with them. And I've used AI a lot, especially Chat GPT, checking drugs. I mean, Hippocrates is what I used for years, but ChatGPT sometimes is easier and gives me more of the information I'm really after. Uh, I had patients call me on things I know very well, and sometimes I'll look it up just to see if something's changed since I've been retired. I want to give you one example of what I did after you were inviting me to this podcast. I wanted to check how good ChatGPT was when I added a very specific issue. About 40% of my practice was oncology, and a lot of that was prostate cancer and bladder cancer. So I asked a very specific bladder cancer question. The question I asked was, give me a summary of intravesical bladder cancer treatments for non-muscle invasive bladder cancer, high-grade cancer. And it spit out a 4-page document that hit every bullet point I could even think of. It was written better than I could write it. It talked about all the drugs. It talked about the potential side effects. It talked about all the options, including combination therapies. So I thought, wow. And I took it another step. Having been involved in research, I wanted to know what research it knew. So I asked the question, can you elaborate on phase 2 and phase 3 studies that are in progress dealing with failures of non-muscle invasive high-grade bladder cancer previous intravesical treatments? And boom, it came out with another dissertation, easy to read, very organized. The studies it pulled up were studies that I was involved in with my other medical advisor role, and it was right on. And so, from an accuracy standpoint, I was incredibly impressed.
It's definitely significantly better than even a year or two ago. And that's the amazing thing about this whole thing. The way it's increasing the speed, the exponential speed at which the accuracy and the abilities of the AI is increasing is what's fascinating and fun and exhilarating and scary all at the same time.
It brought out this information in 10 seconds. If I had to research it online or something, or, your textbooks are out of date when they're printed, uh, it would have taken me hours.
Yeah, I mean, it's interesting, Howard, because 5 years ago, a lot of us were having questions about why do we still have textbooks? Because by the time they got published, they were out of date. So we're moving towards things being online. Now I actually find that you can get these summaries of data in ways that you just couldn't. I don't even use PubMed very much anymore unless I have a very specific thing I'm looking for, because it doesn't give me the breadth and the speed at which AI delivers. So for just sort of searching. I did the same thing this morning, looking at what phase 2B and phase 3 studies had been published on a particular area that I'm working on. It was able to summarize everything. It's pretty amazing.
Okay, Jenny, I want to shift gears a little bit. I want to learn a little bit more about what your team does when it's assessing how to expand AI when you're looking at applications within our healthcare system, the Cleveland Clinic. How do you make those decisions?
Boy, so it is, like most things at an organization like Cleveland Clinic, a giant group decision. I would say that we really have two factors that kind of drive how we're expanding our use of artificial intelligence. One of them is strategic, right? Top down from our leadership. So our scribe projects, for example, were done basically in response to a request from our chief digital officer, Rohit Chandra, who said, documentation is a problem. Go find me a solution for this documentation problem. And at the time, the scribe technology was very mature. And so that's what we grabbed and that's what we piloted. We also do a lot of expansion in response to bottom up demand. So, for example, we had a lot of people requesting, can I use ChatGPT at work? And of course, the use of ChatGPT in a medical setting is incredibly sensitive. So we really did take time and think, oh, what do we need to do? What security do we need to put in place? How can we make sure that we are confident using this technology, that we're not inappropriately breaching our patients' privacy while still giving our caregivers the full use of the technology? Where we landed with that is an instance of ChatGPT that is not web grounded, so it doesn't bounce queries off the web, but it lives on our own secure cloud instance. I think now in 2026, there are different ways of handling this that we might be looking to change in the future, but it's always trying to straddle that line between wanting to make sure that we have the most up-to-date technology and wanting to make sure that that technology is not compromising our security and our privacy.
I use the Cleveland Clinic ChatGPT a lot, and I like it. And I was curious because I also use my private one, and I recently got a free offer to upgrade my private one, and I was curious whether the Cleveland Clinic one was as good as the upgraded private one, and I tested it. It seems to be
Hmm.
as good as the paid version of ChatGPT. Is that what it's designed to do?
I mean, that is incredibly encouraging. That is the goal, right? The goal is to have technologies that you want to use available to you to use safely, so that you don't have an incentive to abstract our data or our documents and take them outside our protections and to use them. That being said, I would love to see more tools at your fingertips. I would love for you to not have to commit to just this particular version of ChatGPT or just this particular tool from this particular vendor. I would like for you to have access to a reasonably complete suite of AI tools inside Cleveland Clinic as well as outside.
Yeah, that makes sense. Anybody else want to chime in?
Yeah, I'll double back on this in terms of options and tools. So within GSK, they have stuff that's embedded. The same issues are concerned about IP specific data not going outside of the system. So we don't use Chat GPT at work. We've got Jules and Gigi and Copilot and other things that are just there. It's helpful to try to figure out which program meets this very specific need. I'm still trying to learn this. I think the challenge is trying to keep up with the different options that are out there so I know which one to use. And the only way you get better at this, like what we've done before, I'm sure if we asked Howard, how did he get better at certain procedures? By doing it. And so with AI, I think you have to dive in and figure out how to pose the question, and get the answers that you sort of, not the answers that you want, but get the information that you want.
And you've got your finger right on a real area of opportunity for governance as well. Maybe we'll get to this a little bit later, but there's a lot of room for improvement in how we educate our workforce on how do you think about artificial intelligence? How do you prompt it? How do you know when a problem is a good fit for AI versus something else?
Jenny, at the Cleveland Clinic, is AI completely integrated with Epic?
What a great question. I think it's dependent on your definition of completely integrated, because AI comes in multiple flavors. Wish I normally try to draw a picture here, right? So there's internally developed artificial intelligence. So that's what we've got a whole crew of data scientists doing things like predictive modeling with our data. And that is often integrated into Epic or into operational systems in a way that is serviceable. And then there is the vendor relationships that we have, like Ambience, right, which is also integrated into Epic. There's native AI into Epic as well. So Epic rolls out its generative AI suite. Epic has predictive models as well that you can take, essentially fine tune on your own patient population, validate, and then push into production. And then there is a fourth box on this matrix that is like open evidence and ChatGPT and the things that people put on their phones and bring in their pockets into the clinic. Those things are often not integrated into our systems, but many of the others are. And I will say that you tend to get the greatest benefit from these when they are meaningfully integrated.
Yeah. Now, Peter, you alluded to this already. Are there other uses of AI in industry that you haven't talked about yet?
Well, in discovery, which I'm not part of, I mean, I'm in early research and development, but in discovery now they're using predictive models around protein folding, enzymatic pockets to try to predict drug structure that might work. So they can scan now huge numbers of molecules to pick out things that might work. There's also a big move now to move away from some of the animal testing to actually use testing using AI or models that are out there that are not putting chemicals into rabbits and rats to try to predict outcomes. That one reduces the burden, obviously, in terms of what happens with animals, which there's a lot of ethical concerns there to begin with, but also may actually give us better information. It's a little hard sometimes to derive the benefit or the toxicity of a drug in a dog when you're trying to give it to humans at some point. So I think that this will speed up drug discovery and development. That's actually exciting. The other part is coding. So now you can put in parameters and it'll spit out code very, very quickly. It'll probably replace a lot of the computer engineers and coders for things. But, like, for instance, we're working on Gemini for protocol development. And this thing will spit out 100 different versions of protocols within a very short period of time. I still think you have to go in and try to look at what your target populations are and steer it in the right direction. But the way that this can put out options is so impressive. It's really changing how we do things.
Very good. Now, I want to segue into the doctor-patient relationship. Howard, let's start with you. Is AI risk weakening the therapeutic relationship, or could it actually strengthen it by giving clinicians more time?
I think it has potential to really be augmented and help the patient and physician by giving the physician more time. That's assuming we're not plugging in more patients because we become more efficient. Some of my concerns are the younger doctors of today seem to have lost the art of physical examination, in my opinion. And I'm scared that AI says this, and they forget, well, maybe I should poke on their belly or listen to their lungs or listen to their heart. And if you're not doing it routinely, you're losing those skills as a physician. I know as a urologist, I had these young urology partners. They weren't even doing rectal exams because they trusted the blood work. And it's like, I can't tell you how many anal cancers I found because I did a rectal exam. I mean, that's my biggest fear, is that we get so efficient that we skip the basics. And I think physical examination is a very important part of the doctor-patient relationship. Putting hands on the patient helps the patient comfort level. No, my doctor does care about me.
Anybody else want to weigh in on that?
Well, anal cancer always gets my attention, Howard. So, because I run the anal dysplasia clinic at UNC. Yeah, I do think that touch matters, and going in and just putting your hands on a human lowers the temperature in a room that might be a little bit hot, or could raise the temperature in a way that feels warming and inviting. There are some things that technology can't replace. I'm sure all of us have remembered walking in a room when you were rounding and you had all the numbers there and the labs, but you just looked at a patient and said, this person doesn't look right. You just knew from experience. You have to do that. You have to go in and have that kind of contact. And it's just experience. And I worry that AI might replace the volume of experience that you need to have really from a clinical assessment that goes beyond just a set of numbers. It's not to say that we shouldn't use AI. Obviously, we're having a lot of discussions there, but it is that other aspect that I worry about.
Peter, are so right. I can't tell you how many times in the OR I would be looking at a situation and my gut tells me, don't go there. And that's just experience. And you can't replace experience. And that experience is by being there, doing it, touching the patient.
Can I ask a follow-up question here?
Sure.
So, for those of you who are practicing physicians, how do you feel the patient's use of artificial intelligence may change that doctor-patient relationship?
It's a great question. We get Dr. Google for years. Now we're going to have Dr. Chat GPT. It's helpful if you don't feel threatened. So I always encourage people to ask questions, and I try not to be condescending when they're asking me things. But the flip side is I worry that people bypass the system altogether because I think our healthcare system's way too fragmented. So rather than entering in, I worry that people may delay care because they've gone online. And again, you still have to have some expertise to interpret the information that's there. So it's a two-sided coin. I think you can have people more sophisticated try to understand things or get engaged. But the flip side is I worry that it may actually delay care, especially in a system in which I worry about people not having healthcare insurance. They're going to find ways of not coming in or taking something over the counter or taking a medication that's on the shelf at home because they think this is the right thing they read on.
Yeah, I want to comment on that too. Like Peter was saying, it was Dr. Google. Now it's going to be that my AI said this, and it's different than what you're saying. Um, there's, I think, a double-edged sword here. I think one of the benefits of AI is it's going to reduce the mundane things that a doctor has to do. A lot of the mundane tasks of refills and simple messages are going to be handled by AI, and then we're going to be left with the more complex, decisions or interactions, and have to navigate some of these questions about, my AI said this, and what do you say? But it's also going to give us an opportunity, I think, whether you're in primary care or specialty care, to create a deeper relationship with the patient and interpret all that's going on. It's going to be confusing for patients. They're going to need someone to help them navigate the healthcare landscape and say, I looked and, ChatGPT said this, and Notebook LM said this, and Claude said this, and Perplexity said this, and, I don't know what to make of all that. And you're going to need somebody to help them digest all that and interpret all that and, have the patients do that. Now, the flip side of that, I think, is it is going to potentially, you know, be a source of burnout for doctors to have to spend that extra time to go over all the different AI versions that the person brings in instead of the mundane tasks. They're going to have to try to weed through all the AI stuff that the patient brings in. But it has the potential to create more therapeutic relationship. And I think the need to have a physician or a cadre of physicians that you trust is going to be even greater because you're going to be inundated with information, is the way I see it.
Well, it comes back to relationships again. I think if you establish a trust relationship with your patient, that changes the way conversations happen as well. But again, I think there's been so much fragmentation that I hear from friends of mine who can't find the same person every time they come into their primary care provider. They're seeing someone else. And that part, again, is worry is going to get lost because of this whole thing that Elliot, you were talking about. How do you take this wealth of information? You have to have a relationship with someone and have a sense of how that works, the conversation, trust, etc. So you're not going through every single thing every single time. And I think, we'll see if we can improve on care.
You know, I think that having patients come in educated or semi-educated is helpful. And our job is to educate them further to where they fully understand what we're trying to tell them. I always encourage patients, if they weren't 100% comfortable, seek another opinion. I won't hold it against them. It won't bother my feelings. but you have to have trust in me. And if you don't trust me, you're better off with somebody else. But having knowledge that they might get from ChatGPT, I find helpful. And I don't look at it as, you know, questioning my ability or my knowledge. I look at it as a point to develop the learning process of what they're going through. I mean, I know the condition backwards and forwards. They may just be getting it for the first time.
I think if it's helpful to engage in the person's healthcare, then it's a really useful tool. And so encouraging people to read up on stuff and go there and knowing that it can actually be written in a way that they can understand can actually be really useful. There have been times where it's been reinforcing what we're trying to do as opposed to a wedge. And I totally agree with you, Howard. I always encourage questions and liked it when someone was engaged in conversation. It made me actually anxious if someone said, "Will you tell me what to do?" I'm like, "Well, no, this isn't how this relationship works. I give you my advice and we make a decision together on this, what's best for you. Ultimately, it's your call." And same thing, if you're not sure, yeah, I want you to find and talk to other people.
Let's talk a little bit about medical education, and I'm going to tackle this question since I'm working in medical education. Are we in danger of a generation of doctors who can't think without AI, or is that the wrong way to frame it? I'd say we're not de-skilling, it's different skilling. It's something that we have to get adjusted to. I have to get adjusted to it as an old school educator. As Howard was saying, we're doing less physical exams, more reliance on tests like echoes and ultrasound. We're also doing, less time consuming tests like doctor collected vaginal swabs and clinician microscopic analysis. I still love doing that. I can hardly get anybody to look in the microscope with me anymore. And we just send the tests to the lab. The same is true for AI. We may be less hands-on typing for the clinician, but more FaceTime. Simple refills are going to be auto-generated, but we're going to have more time for complex evaluations, less time thinking about differential diagnoses, but more time processing the emotional reactions or thinking about the support systems that the patients have and, developing those therapeutic relationships. So those of us training doctors, we really need to think about incorporating AI into our training and into preparing the doctors for the clinical care to make sure that they're using the latest tools. So we thank Jenny and her team for always having those latest tools available to us. Anybody else want to weigh in on that?
Yeah, I'll jump in. We should be Luddites. So, the idea that we used an abacus to do mathematical equations wasn't a reason to move on. And, you and I, Elliot, we entered in. I remember using the slide ruler in high school before we moved to calculators. And then we didn't have laptops, we had desktops. So the idea that you should just stick with something before doesn't make a lot of sense as technology improves. I think the challenge is what you've already said. We have to incorporate a new way of learning and prepare sort of students and residents and house staff to use AI in a way that actually complements what we're trying to accomplish as opposed to putting up barriers where we're not going to use it. I don't know what that is yet. I have conversations with my son who's graduating from college this year about what are they doing in classes to incorporate AI. And I think we need to take that same thing for us with medical education.
All right, Jenny, another question for you. And this is kind of a tough one. AI is not going to be perfect. When AI influences a decision and it causes harm, who should be held accountable? The clinician, the institution, the developer? Not the developer, of course, but
I'm reminded of one of my favorite headlines by one of my writers, one of my favorite writers in the health AI space. It's Sergey Polvikov, and he has a great article from 2024 called "Doctors Go to Jail, Engineers Don't," which really sums up the risk and liability proposition in healthcare right now. I found the wording of this question so interesting, Elliot, because you didn't say who is accountable. You said who should be accountable. And those are different answers, I guess, to me. So there's actually an area of robust research right now in bioethics about when a doctor and an AI system disagree. How do you navigate that disagreement? Because the disagreement between colleagues is well navigated. But when it's a doctor versus an AI, or worse, a doctor versus a doctor and an AI, how do you navigate this? So literally next on my to read list is a paper on how do we come to a conclusion when you have not only a disagreement with your colleague, but also with an artificial intelligence system. To get back to your actual question, I think the true answer lies in how was the system designed? Was it designed to have a human in the loop where the AI is making a suggestion and then we are relying on an individual's clinical judgment and they're the ones who are actually taking the action? That's what ambience is, for example. You are the human in the loop. They're presenting you with a draft to review and you are reviewing it and signing off on it before it goes into the system. If we have instead a human on the loop where somebody is reviewing decisions that are made after the fact. So if I have a tool that perhaps is monitoring patients inpatient for sepsis and it's triggering alerts and the alerts are going to the medical response team, but I, the doctor, am looking at this after the fact to say, do I agree with this? Do I not? There's not really a chance for me to go back in time and to exercise that clinical judgment. So it's difficult to say, that doctor is accountable. I think there's a lot of nuance in how responsibility is handled because it is entirely possible for a developer to create a system that offloads all of that responsibility to the clinician because, we put a human in the loop. And then it's perfectly possible also for an institution to deploy that software in a way that effectively removes the human from the loop. So if Ambience gave us software, and we would never do this at Cleveland Clinic, just saying, but if we automated an approval rather than having you review and sign off, then we've effectively removed a human in the loop. I think case law is going to continue to develop on this. I am not yet quite, I don't know if we've had any cases go through the courts yet where we're trying to look at who holds liability when there's a disagreement or when there's a mistake on the part of an automated system, but we definitely will see it. And I'm following this really closely. I think it's going to be really interesting.
I agree with you, Jenny, quite a bit, but I'm a little old school here. And being a surgeon, it's like if anything happens to the patient when they're in the OR, it's my responsibility. Anesthesia screw up, scrub nurse screws up, the floating nurse screws up, the rep that brought in the equipment screws up. I'm the leader of the ship. It's my fault. Now, with AI, I'm making decisions on the information it's giving me. So if it gives me information and I go by it, but it's not correct information, I still think it's my fault because I should know better. And it's a tightrope to walk, but being old school, that's kind of how I look at it. It starts at the top. And I think the top is what's going to take the fall for.
I agree with you, Howard. Ultimately, I think those systems are going to have the physician review whatever an AI comes up with. Although, as I was saying, Utah is the first state that's going to have refills. The first 150 or so reviewed by docs, but then they're going to be automatic. So there's going to be situations where, hypertension med is reviewed and approved, and is that blood pressure controlled? Has anybody been checking electrolytes? I don't know how that's going to be done. And if somebody has a stroke, they're going to come back and say, why'd you refill that and you didn't, look after me? So I do think there's going to be some interesting case law coming down.
So Jennifer, in terms of probability, a lot of this comes down to probability and error. What will there be benchmarks with AI about what is an acceptable error rate? We think of them as being perfect, but they're not. So I just don't know what the answer is. I'm curious to see if that's being developed or.
So I think right now today, the gold standard is to develop benchmarks for each individual tool, right? Because a positive predictive value, a negative predictive value for a sepsis detection tool carries very different implications than, something that might be coaching me through managing my hypertension at home, for example. And so I think it's important to think about not only to define really clearly how good does this have to be in order to be useful. Accuracy is acceptable in order to be useful to us. And then also to think about none of these tools are really operating in isolation. So we're never leaving patients in a bunker alone with only an AI monitoring them for sepsis. There is a whole patient safety stack, the nurses, like everybody is around like is I'm saying this really poorly. Everybody is there in service of keeping the patient safe and healthy. And so we also need to take the risk that a particular AI system may make an error and place that in the context of all of the other safety systems that are there. And that's when you get into really interesting nuances with things about like hospital at home. Or, I mentioned an app that might coach me through a recent diagnosis of hypertension or of diabetes. If I'm operating on my own, then there's less of that safety. So the risk just sort of shifts back and forth depending on your environment and how many other medical professionals are there to serve as also guardians of patient safety.
Great. Very interesting discussion. I agree. We're going to definitely hear more about that. Now, Peter, I'm throwing this at you. I don't know if this is something that you're ready for or not, but I know you think about this or have in the past. What do you think about AI in healthcare disparities? Is it going to reduce those or quietly make them worse?
I think it's potentially right now make it worse because I think the gap is only growing about who has access to technology. And I don't see the resources being put out there. It has the potential, if we allow access, to actually level the playing field. Because if you have a phone and you know how to do things, you can at least get some access. But ultimately, it's about access to healthcare. And I think we're actually taking steps back as opposed to moving forward in this country. And that's the part that I really worry about. And I don't think AI can fix what is probably a policy question. So, in some ways, if you have access, which is probably related to having a job or having money, you're probably going to benefit from this while other people may not. And so I don't think it's going to fix the disparity unless we actually fix some of the policy issues that are there and some of the health inequities that exist in our country.
Anybody else want to weigh in on that? All right. Lastly, and this may be the toughest question to each of you, I want to hear your thoughts. If you could set one hard boundary, what should AI not do in medicine? What should it never do? And what are your thoughts? Let's start off with you, Peter.
Boy, this is a hard one. I have to actually give this a lot more thought, Elliot, but just off the top, we talk about some of these life and death decisions about stopping care. That I think can't be done by AI. That's a personal decision. So when it comes down to some of these decisions, even about whether I should have a procedure or not, I don't want AI to do that. I think we have to maintain this loop for someone to decide what's best for them.
All right, Howard, how about you?
I think a very hard stop for me is that AI should never be able to make a decision without oversight of a physician. Okay. That's a hard no. It's got to be reviewed and signed off by a doctor. Another thought that I have, having a daughter who's a medical ethicist, is that I think from an ethical standpoint, AI should be reviewed periodically so that we know AI is not going beyond the bounds of what we intend it to do.
Jenny, how about you?
I'm going to tackle this from a slightly outside the health system lens because I'm reading a recent paper about the performance of ChatGPT Health. So I'm thinking about patients' relationship with AI. And I'm going to say that AI in medicine should not act as an additional barrier to receiving care, whether that's the substitution of AI for medical advice or whether that is relying on an artificial intelligence system to tell you when something is worth going to the ED or not. I would love to see AI serve as a conduit for better patient-doctor relations and not as a barrier to access.
To take that one level further, how often do you call a service department and you're talking to an AI robot, and all you really want to do is talk to a real person because you have a question they really can't answer, but you're in this endless loop of misery and there's no way out. I don't want to see that happen in medicine. And that's
Because you're not in the exact algorithm that they're in, and they can't figure that out by talking to you. The one thing I was going to say is that one of my favorite authors is Yuval Noah Harari, who wrote *Sapiens*. One of his follow-up books was *Homo Deus*, in which he predicted that algorithms will get agency at some point. they'll become persons in the future. Basically saying an AI will become a person, will get legal rights eventually, which is a kind of a concern to me. So I would say I don't want an AI to get a medical license and have full agency to make medical decisions. I agree with Howard and Peter that medical decisions should be made by humans. I think there are certain things you could delegate over, and refills under certain circumstances. You can delegate to nurses and others, and I think those can be delegated with proper controls to an AI. Real medical decision making, I think, needs to be done by humans. At this point, I can't foresee that in the near future that would be something that I would not want to give an AI medical license at this point. All right, well, this has been a fascinating conversation for me, and I would like each of you to have a final word. Jenny, you might want to plug your own podcast. I don't know how often you put those out, but that would be kind of interesting to hear about.
Yeah, absolutely. So I run a podcast on the side because I don't get enough talking about AI at work. It's called Health Data Ethics. It is usually published weekly. I have a bunch of really interesting episodes coming up about the performance of ChatGPT Health, a deep dive on some of the Joint Commission and the Coalition for Health AI guidelines on the use of responsible AI in healthcare, and more.
Where do we find your podcast?
You can find me on LinkedIn or on YouTube. If you look on YouTube for Health Data Ethics, you will find me.
Excellent. All right, Peter, any last words?
Yeah, I'm going to follow Jenny's podcast. I think we will be dealing with this from here on out. The world is definitely changing. We have to figure out how to stay engaged in the discussion. And this is a great way of kicking off, at least me thinking about this more in a much broader context. So I appreciate the invite, Elliot.
Well, first of all, Elliot, I want to thank you. And for you that don't know, I've known Elliot his entire life. We are genetically brothers. So I love him and I respect him. And he's one of the smartest people I know. And I just want to say thank you to Peter and Jenny. It's been such a pleasure talking with you both. You're both so sophisticated and knowledgeable in your fields. And I'm honored to be part of this conference with the three of you.
Well, this has been really wonderful together. I want to thank again Dr. Peter Leone, Dr. Howard Abramowitz, Jenny Owens from the Cleveland Clinic, a senior analyst. What is it? What's your title exactly?
AI Program Administrator, which really doesn't.
I like senior. Senior's good.
Yeah,
Senior whatever.
AI program administrator.
AI person.
Was your background in C?
No, not in the least.
Okay, well,
You're gonna have to tell me how you got there then.
This has been exciting because it's our very first roundtable, and I hope it's going to be one of many. And so I appreciate you all jumping on board and learning with me the process of doing a roundtable. And it actually hasn't been that difficult. It's been a lot of fun. And I hope to have more interesting discussions in the future. And, I heard people complaining the other day that they're so sick of AI. They're so sick of AI, they can't believe it. I know. I was just feeling sorry for them because we are just getting started. This is the beginning of AI. It is nowhere near anywhere at this point, and they better get used to it because it's going to be with us for a long, long time. And I hope to bring a lot more interesting discussions. And for all of you, I'm so excited for spring. I love being able to have lived through another Northeastern Ohio winter and be able to welcome a Northeastern Ohio spring. And remember to stay healthy out there.
The preceding podcast contained discussions of medical cases where names and identifying details were altered to protect the privacy of individuals. The views and opinions expressed were those of the individual speakers and do not necessarily reflect the official policy or position of any affiliated institutions or organizations. This podcast was for entertainment purposes only and should not be taken as medical advice.